afternoon, everybody. It's great to see, and it's great to see such a vibrant and a very enthusiastic crowd. Welcome, everybody, and it's wonderful to see you both here in the room, and we have quite a few number of people who have been able to join us by Zoom. Let me start by saying it's really hard for me to believe that tomorrow is actually my last day as dean, and this is the last time I have the honor of introducing an incredible member of our faculty. So it's a particular wonderful time for me to be able to introduce you, Karin, for this lecture. I will also say that I am just thrilled to welcome Keisha Pollock-Porter. I hope you'll all come out tomorrow morning and welcome her as our new dean. I think many of you already know Keisha and know that she is the absolute best person for the job right now. And she will be an incredible dean and will lead our school through obviously very challenging times. But as I said, I think she has what it takes to lead us at this point in time. At any point in time, but particularly this point in time. So I'm thrilled to welcome her as a new dean, and I also look forward to sitting back and attending these lectures as a member of the audience. That will be nice. As we all know, these lectures give us a reason to come together and learn from some of our amazing faculty superstars. We benefit from their experience and their fresh ideas, and we are inspired by everything they are doing to change the world. As you know, these lectures recognize our newly appointed and promoted professors as well as senior scientists. Each of these promotions and appointments is an exceptional achievement, as well as a mark of the high regard that our professors and senior scientists are viewed by colleagues both within this school, but clearly around the nation and the world. And today I'm so very pleased to be here introducing Karin Tobin. Now, Karin, as you know, is an alum of the Bloomberg School and a professor in our department of Health, Behavior, and Society. She is also Associate Director of the Lighthouse Studies at Pierpoint, our community-based clinic, and she is the Training Director of our Overdose Response Program. So to begin, I'd like to tell you a quick story about Karin, which I think will tell you a lot about who she is and what she does and how she contributes to the public's health. A few years ago, Karin and her colleagues at the Lighthouse were discussing the age-old question, if you won the lottery, what would you do with that money? In the classic public health fashion, Karin did not say, well, I'd buy a lot or a lake house or even contemplate an early retirement. If Karin won the lottery, she would open a harm reduction center. So, yes, that deserves some applause. A very atypical answer, but this embodies who Karin is. And today, if you walk past the McElderry building, you will very often see a metal cart flanked by eager young students. The cart is filled with syringes, smoking kits, Narcan, and even instant ramen noodles. And all of it is free, and it's there because of Karin. She first launched this project during COVID, when so much of the world was closed, and she was worried about the health and the safety of our neighbors. At first, she just had a table with some harm reduction supplies, as well as undergraduates who were very helpful and were there willing to help. Eventually, it evolved into a cart and a club known as the Hop-On Harm Reduction. As the faculty sponsor of this project, Karin helps the club obtain materials and maintain best practices, and is a true passion project for her. You will see the cart in operation Monday through Friday, even in the rain, even in the snow. The club provides thousands of harm reduction supplies to hundreds of people in our community here in Baltimore. So Karin may not have won the lottery. You still have an opportunity to do so. And she might not have a whole center quite yet, but she is working every single day to fulfill her goals and to put public health into action. And the card, of course, is just one example of Karin's work. A social and behavioral scientist, Karin conducts research in urgent areas including HIV, STIs, mental health issues, as well as addiction. Specifically, she focuses on identifying the social factors associated with health and risk, and then developing and testing behavioral interventions. She works with key populations, including people who use and inject drugs, and uses a harm reduction framework to guide her research and her practice. In fact, Karin has developed close to 15 behavioral interventions focused on HIV prevention and HIV prevention and testing, sexual health, drug use, and hepatitis C. 2 of these have actually been officially recognized by the CDC as evidence-based interventions. Karin has also done important work to identify gaps in naloxone access and training, helping us work toward greater uptake of this life-saving medication. And recently, she has been developing a toolkit that can be used by other sectors, including law enforcement and housing, to increase organizational capacity for gender-affirming care. Again, these are just some examples of the incredible work that Karin does. And we'll no doubt hear more on these topics, and including health equity, behavior change, and community engagement. And truly, Karin's work is deeply rooted in the communities that she serves. Every day, she and her colleagues at the Lighthouse connect and engage with the people of Baltimore. They meet them where they are to provide the help they need. To quote a staff member from the Lighthouse, Karin has courage, strength, compassion, and heart, all the characteristics one needs to do this kind of important work. So Karin, thank you for showing us what it means to live the mission of public health. And we are so grateful for all that you do, and we are looking forward to your presentation today. So please join us.
Thank you so much for that really kind introduction, Dee McKenzie, and I'm truly honored to give this talk. I am nervous, and I didn't expect this many people to show up, but I will get it rolling, and you actually gave a really nice preview to my talk. I'm going to be presenting my work from 3 different perspectives of how I approach looking at social networks to be able to improve community health and health outcomes. And one of the realizations I came to as I prepared this talk was how much progress our field has made over these past 20 years. And it makes me really proud to be able to present some of these findings. I know that when I meet with students, they often get so frustrated because it seems like nothing ever changes. And I just say, it's a marathon, it's like an ultra marathon, just hang in there. So hopefully all of you will leave here with a sense of optimism that despite these challenging and critical times, we can continue to generate the evidence that we need to support the policies to improve the health of our communities, and all communities, and achieve health equity. So before I get started, I'm going to tell the stories, which some of you have heard, about how I discovered public health and research. Uh-oh. It's not fast forwarding. Let me try this. Nope. Oh, there, perfect. Oops. Let's go back. Okay, so I graduated from my undergrad in the early 90s. I know some of you were probably not even born yet. I majored in psychology, and at the time, HIV and AIDS epidemic had started really hitting Baltimore County because of people who use drugs, and particularly injection drug use. So I interviewed for a position at the county health department, and despite having very little knowledge, in fact, 0 knowledge about HIV, and no experience or knowledge about program planning, evaluation, or health education, I got the job to be the county AIDS outreach specialist. And in this position, I self-taught myself about what is HIV, how do people get it, what do I think the people in the county need to know. And for the next several years, I developed several programs and implemented several programs that aim to reduce HIV and came to realize my passion for developing programs. I didn't realize at the time they were behavioral programs, but they were a lot of fun, and the people that participated in them really seemed to like them. So one of the programs was I went into people's homes and demonstrated safer sex practices, including condom demonstrations. It was a little bit embarrassing because my parents were like, "What do you mean you're the condom lady?" But I did that, and I got to meet lots of folks through the county that way. I learned about the link between alcohol use and HIV risk and did a bar party where we gave away condoms that we designed ourselves.
Johns Hopkins right now.
Oh, someone's not me. Oh, Mark, of course, my brother. I also did an event at a clinic that provided HIV/AIDS services to kids living with HIV to really raise awareness about the stigma they were experiencing. And I did a lot of updates and newsletters to the addictions professionals in Baltimore County so that they understood the best practices and the evidence as it was literally coming out. So after doing that, I was appointed to be the adolescent treatment coordinator for Baltimore County, which entailed a 5-week course teaching really not happy adolescents who got busted at school or by their parents smoking weed, who had to attend my 5-week program. This was where I probably learned at first, like, know your audience. And so I was preppy when I was at Towson. I was grungy when I was in Essex. And this program also entailed me taking them all to shock trauma to show them the traumas associated with drug and alcohol use. And for those of you who are not trained up yet, as behavioral scientists, we know fear doesn't work to change behavior. So had I known that then, I would have canceled this part of the program. I was also featured in a book on healthcare and wellness as a substance abuse counselor. And that made me realize, like, well, maybe this is actually legit work. I still felt like I didn't know what I was doing and I was learning every day. But I realized that maybe just keep looking for these opportunities. And so what I tell people today when I mentor is stop trying to have the perfect plan. Just look for the opportunities and things will start rolling. I then interviewed for a position here at Johns Hopkins Bloomberg School of Public Health in the Department of Epidemiology as a project coordinator or director for a vaccine preparedness study. This was back in 1997. So they thought a vaccine was coming out and that we wanted to know whether the community of people who use drugs were ready for this and what information they needed. The study was being led by a junior faculty member named Alice Tang, who was my mentor and Hi, Judy, who is my mentor and is still a great friend to this day. I found myself in the interview showing them all of my little flyers and my little gadgets to the legendary epidemiologists, David Vlahov, Ken Nelson, and David Celentano. And I had no idea who these guys were, and I'm glad I didn't because I think I would have been so nervous. They were setting up the Alive cohort. Like this was what they were doing. I remember them telling me that, the data were on cards that you strung through a machine, and I didn't even know what data was at the time. So again, another theme, despite having no experience in research or even knowing what public health was, I got the job. So then I found myself in this position saying, despite being a substance abuse counselor, I don't know anything about drug use, much less injection drug use. And so I was introduced to Bert Queen on the left, who worked for the Alive study, and who introduced me to Tanya Johnson, who I hired and have worked with ever since. And they spent months with me out in the streets of Baltimore, showing me people buying drugs, people using drugs. I got to witness the pulse of the urban city. I grew up in the county, like Harford County, so very rural. And I got to see the pulse of urban living in areas characterized by poverty, by crime, and by need. But they also showed me the faces behind the numbers and the humanity and the resilience of the people that were out there just trying to survive every day. And they taught me a very important lesson, Ms. Johnson, that in order to be credible, you have to be authentic. And I've carried that lesson with me ever since, so thank you so much for teaching me that. Eventually, I ended up at the Lighthouse, which you've heard a little bit about, and I started working under the mentorship of Carl Latkin, and I learned about behavioral interventions and social networks, and I was like, this is my tribe. I had been taking EPI classes and loved them, but it wasn't my tribe. So these are some of the fantastic people that work at the Lighthouse. They have supported me throughout my career. They have also trained countless undergrads, grad students, postdocs, clinicians that have come through our doors who've wanted to learn how to develop behavioral interventions or just work with people who are using drugs or sexual minorities. They're a tremendous asset to the school, and I know that they know that, but I just wanted to make sure everyone here knew it. Okay, so on to my work. So I pursued, after all of these years of running projects, I pursued a master's in health science and the Department of Mental Health, and then a PhD in the Division of Social Behavioral Sciences in the Department then of Health Policy and Management. After that, we became our own department. And my career's been dedicated to really working to achieve health equity for people who are the most marginalized because of their sexual identity, because of their addiction, because of their infectious disease status. And so there are 4 kind of general themes to my scholarship that I'll be talking more in detail about. First is that my scholarship aims to generate evidence on the social determinants of health with a real focus on social networks so that we can use this evidence to generate social network-based interventions. Generating evidence on the role of place-based context, which also shapes social networks and health outcomes. Sustaining effective community partnerships, and how this also can create or shape new social networks, which we really need to be able to get the work done. We can't do this on our own. And finally, centering harm reduction as a lens through which all this work happens. So when I first started in my early days of research, I was really pretty solely focusing on the social networks of people who use drugs in the context of the HIV/AIDS epidemic. And from this research, we learned that social networks really do matter. At this point, social network research was fairly early. People were focusing on what are these individual level variables? Do they know enough? What are their attitudes? But this work really extended that focus into more of the social influence of what's creating risk or causing health outcomes. So what we learned is that the composition and the structure and the function of the social networks mattered. For example, having more injectors in your network was associated with greater HIV risk behaviors. People who shared needles and cookers with each other endorsed norms that encouraged other people to share. So they would say, yes, I think most people share cookers and cottons, and that's why I'm sharing cookers and cottons. And you should, and if I think most people do, then most people do, and that's going to encourage people to do that. Social network correlates, social networks of people who use shooting galleries. So for those of you who don't know, a shooting gallery is a public place that people go to inject. And usually there are discarded needles, dirty water all over there. So people that go to these high-risk areas tended to have a much bigger network and also have a lot more crack smokers compared to people that don't go to the shooting galleries. And also we learned that having people in your network with whom the more people you had in your network with whom you had conflict, the greater odds of you having a non-fatal overdose. And so these are all pretty negative associations of risk, but we also did learn that having somebody in your network that was tested for HIV was associated with you being tested with HIV. So we applied these findings to develop peer-based interventions. And the way these peer-based interventions work is we train one individual who we know exists naturally within a social network. We all do, if you think about it. And we know that not only can this person influence people in their social networks behavior, but the people in their social network can also influence them. So if we can introduce and diffuse information, skills, and resources, then the network becomes a self-sustaining process if you introduce, the right behaviors. So in one of the interventions, my team developed this communication tool to guide their conversations. What we learned was that people were extremely excited and enthusiastic to go out there and share the information that we shared with them and to show them new skills. But oftentimes when they would do that, they would jump up on people and start out in a pretty negative and stigmatizing way, telling everybody what they were doing wrong. And nobody wants to be told that they're wrong. So we wanted to come up with this tool to really start out by being positive, point out what people are doing right, then you can figure out what they're doing that's risky, and then you can give them options for reducing that risk. As Dean McKenzie said, this approach has been recognized by the CDC in the Compendium of Effective Interventions, and we actually even worked with the CDC to create a toolkit to disseminate to different NGOs and health departments so that they can implement this intervention themselves. Although, and that's all really great, like that type of impact is fantastic, but one day Tanya came to me and said, can you come out and talk to a participant? He's here for a visit and wants to talk to you. I was like, sure. Not knowing what to expect. So I went out and saw this really clean-cut guy, tall, good-looking guy. He looked like he was a college student or a fraternity at Towson University. I was like, hey, how are you? And he said, I just wanted to let you know that this program saved my life. It got me off the streets, it got me into treatment, and I just wanted to make sure I thanked you for the work that you guys are doing. So that was really, and thank you. We have, that's why I'm at my clinic a lot, because being able to interact with the participants is really, it's important so that we are developing programs that literally speak to their lives, and I'll say more about that when I move on. So we then developed this, this framework or this model that talks about the essential program components of a peer-based program to be, and the behavioral mechanisms through which these components, education, social support, and social norms, leads to improving health outcomes. We did a scoping review on this and found that very few of the programs that made it into our scoping review actually described the role modeling and self-efficacy aspects of their program. We know that people learn by watching someone do something and then practicing it over and over again until they believe that they can do it, which is what self-efficacy is. And so it's really important that when I train people to develop behavioral interventions, or I talk about it, I talk about the importance of cut out some of the stuff where you're just jabbing at people and give them chances to practice. Most people don't have somebody show them how to use a condom properly. They just think they know how to do it. But then when you actually walk them through the steps, they realize, oh, I'm not doing it right. And then when you get them to practice in front of other people, then they're getting feedback about what they're doing right or wrong. And that's how we get to be able to change behaviors. So in our behavioral interventions, we have our facilitators role model the behaviors we want to see, and then we have the participants go out and role model the behaviors that they want to see in their networks. And as I always lecture in Vanya's class, if you're going to take that, you'll hear more examples of that. Okay, now I'm going to talk a little bit about my work in the opioid epidemic. Okay. So this figure shows the 3 different waves of the opioid epidemic. And we're actually in wave 4, which is characterized by co-stimulant use with the opioids. 2001 to 2004 was when I was in the doctoral program here. Some of you still probably weren't born. My dissertation, at the time that I was in the program, the epidemiologists were doing a great job pointing out what are the reasons why fatal and non-fatal overdose exist or happen. You know, it's this lowered of tolerance, it's co-occurrent use. But nobody was really focusing on the social factors associated with overdose and with calling 911, which at the time that I was in the program was the only way that you could get naloxone, which is a medication that reverses opioid overdose. At the time, if you were overdosing and someone called 911, paramedics would roll up and give you an IM injection of naloxone, and they usually gave a lot. So people did not like calling 911. But this was one of the solutions to being able to get the overdose deaths down, mortality. So what my research found was, yes, indeed, individual level variables like previously overdosing or previously witnessing an overdose was associated with an increase in calling 911. But we also found 2 social level factors that were associated in different directions. So we found that the greater number of bystanders present at an overdose, the lower likelihood of calling 911. And this is really attributed to that diffusion of responsibility phenomenon. However, the greater number of women or females that were present, the odds of calling 911 went really far up, which speaks to the caretaking aspect, perhaps, of females. in one of my classes with Deborah Roeder, her health literacy class, I did a project which developed a photo novella of what to do in case of an overdose. And this included, so what we were teaching people, shake the person, ask if they're okay, do a sternum rub, because if you're partially conscious, this is painful. If you try it on yourself, it's painful. And then calling 911. I'm teaching them about the Good Samaritan law. And we also address things not to do, like submerging somebody in ice cold water or making them drink milk, which was one of these rumors that people believed. So after we did this, Carl, Susan Sherman, and I shared this with the health department, who was trying to figure out what should we do about this overdose problem. And so we helped them develop the Staying Alive program and trained them to implement it. And since then, according to them, they behaviorally trained people in the Staying Alive program for over 3,000 Baltimore residents, which is pretty impressive. Then, in 2015, the FDA approved Narcan, which is a nasal spray of naloxone, to be used. And in 2015, Baltimore City issued the first blanket prescription so that anybody could access a prescription of Narcan. And then the following year, the state issued the blanket prescription so anyone in the state could have access to free naloxone. And then the state set up this really fantastic, their Center for Harm Reduction Services, which gives us all of the free naloxone that we can give out, the fentanyl test strips, xylazine test strips. And so to be able to see like a structural change in response to this problem was very gratifying as a public health person. So all of this was really great progress. We ended up doing a study that pointed to some gaps in what the programming was doing. And you can see from this cascade that, you know, the saturation of people who had heard of naloxone at the time we did this study was pretty good. People reported that they had access to the naloxone programs and that some of them had been trained. But what we found, the big drop off here, was the people who said that they often or always carried naloxone with them was very low. And so this kind of opened our eyes to pivot some of our interventions, that it's not enough just to know about it and know how to use it, but we have to develop behavioral strategies so that you never leave the house without it. And if you use it, go and refill it. That's another thing that happened that we were told. So you've heard about all these wonderful people, but here they are again. And here's our first janky cart with the plastic bins. And then there's our nice metal cart. And yes, indeed, they are out there through all kinds of weather. They were out there in all of this heat. And can I embarrass you guys and have you raise your hands if you were or are a volunteer? Yay. And let me tell you, we've been getting busy. I don't know what's going on out there. Okay, so now I'm going to talk about my work examining place-based context and how this shapes social networks. So I shifted my research to focus on sexual minority Black men who were at risk of HIV because they continue, despite all of the epidemiology, they continue to experience greater disparities in infection and not accessing treatment compared to white men who have sex with men. One important finding I found from this initial research was that their social networks were very diverse. Like, I think there was a stereotype in the field that Black sexual minority men only hung out with Black sexual minority men. And that is not the case. And I think that's an important stereotype to bust up. So their networks had kin. They had Black male friends that weren't sexual minorities. They had lots of females. And so this level of more detail about who they are also tells us, well, who are the people we should be talking to about improving, risk reduction? Like, we don't always just have to talk to sex partners. We can talk to their female friends. And that was kind of a novel idea at the time. I also learned that their networks are very spread out, and Baltimore's not a big city, but so you can, if you're new to Baltimore, basically the Charles Street kind of divides us in half, northwest, and North Avenue divides us in half. You know what I mean? And so I was awarded, and so I really thought about, like, how does the city and the geographic nature of behavior influence health outcomes. So I was awarded a KO1 award and conducted a study to really look at how do these places where people spend their time, men spend their times, where are they and who are they with? And so the first study I conducted was qualitative. And basically, I would do in-depth interviews asking people to describe a typical day for them. And I would sketch out their path and just kind of check in with them to see whether I was accurately reflecting, where they were going. And the reason I did these maps was because I had a hypothesis that because of racism and homophobia, their paths would be very constrained. They wouldn't move around a lot. In fact, I found the opposite, that this was a very walkable city and people moved around a lot. This isn't the best example, though. And so what we learned was that the paths and routines that people took were really characterized based on two major things. One, whether they were employed or were a student, and two, whether or not they had addiction. So the people who were in school or work, their routines and patterns were very predictable. You get up, you go to work, you stop off at the grocery store, you come home, and you do that every day. We had guys who were using drugs and alcohol, and guys who were unemployed, and when they woke up, they were like, well, let's see where the day takes me. So what we learned was that actually the HIV risk among the people who were addicted to drugs or using alcohol was actually much lower, in part because they were constantly being targeted with prevention messages like, you guys are the risky ones, be safe. They also knew they were the risky ones, so they came prepared to take care of themselves. It was the more routinized guys that didn't have any HIV risk planned in their day, but ones that might end up at a bar after work and then, ended up in a car with somebody and didn't have what they needed to be safe. So that was a really surprising finding. We also learned about places that that these guys avoided because of undesirable behavior, like violence or drug use, that they had identified several places of escape where they described, I just want to go there so no one knows me, no one's in my business. Baltimore's a very small city, people are in your business a lot. And then unfortunately, this layering of places where guys went for leisure to have fun, but were also places one avoids. So the bars and club scenes were usually talked about as, I love going out because I'm with my people, but then somebody always gets dramatic and you gotta leave the place. And not a lot of places for leisure. So I then I'm not a qualitative researcher, and that was the hardest paper I've ever written in my whole life. And so that I was like, let's quantify this. So I created a quantitative tool to assess the intersection of social networks and place. And we've since applied these methods to a sample of young sexual minority girls, women ages 16 to 24 in Baltimore with my colleague Kamala Alexander from the School of Nursing. And what we learned from that study was that these were girls that had experienced intimate partner violence in the prior year. And what we learned, though, was that the violence that they were experiencing wasn't just always happening in the bedroom, and it wasn't always by intimate partners. And so we since then have expanded our research and our focus on, who are these other people in the networks that are perpetrating violence or harm to these Black women? We also used these methods with my colleague Jill Ocharzik in Ukraine with people who use drugs there. And what we found was that people who were using drugs were traveling to the Ukraine is very different. Unlike here where all of our drugs are powdered, their drugs are all liquid, they come liquid. And so people who use drugs would travel with their social networks to these places and hand over their syringes to be filled by some random person, which obviously shaped a risk profile for hepatitis C and HIV risk. So we did that. And my last example of place-based context is I started working with this fantastic nonprofit called APAT, which stands for Access to Prevention, Advocacy, Intervention, and Treatment. And here's my colleagues. Jerry on the left is the director, and he's also a DRPH student. I talked him into coming and getting a DRPH. Melissa Davy Rothwell and I conducted a program evaluation on the first transgender-only housing program in Los Angeles. And it's called Casa Zuma. And what we did was we interviewed residents of the house as well as staff. And this is the first house, and it held 16 beds. And you can see from the staffing list that it wasn't just housing they were providing, it was a lot of wraparound services. And that they were allowed to leave their house daily, but they didn't have to. A lot of interim housing programs in California, like at 6 o'clock, you've got to get out and you can't come back till 6, which is not exactly confer safety upon people if they're roaming the streets for 12 hours. And so one of the first, significant findings was that they saw this housing program as an affirming space, and it generated feelings of validation of their identity, safety, and security. And if you don't feel safe and secure, you're probably not very likely to take care of your own self and do all of these public health prevention things that we're telling them about. I pointed this second quote here that says, I'd say it's a place you can feel like you can come home to be safe. There's a sense of community. There's a sisterhood. So they're already talking about how this place is creating social networks for these women. As I mentioned, with the staffing, they got the housing programs, and I just saw that Trump, I don't know if I can say that, but he's getting rid of Housing First programs, which is horrible. Housing First is basically low barrier housing where you don't have to be clean and you don't have to get mental health services to take advantage of the housing services. But then oftentimes people get frustrated because they're like, well, we gave them a bed and we gave them some food and we gave them a shower. Why aren't they better yet? Well, because there's a lot of trauma going on in the background, and they also need things, the transgender community, they might need help with ID services. Living on the streets, you get robbed a lot. They get, financial literacy, they get all of this at the house. And you can see from this quote that this person spoke to the importance of having all of these services available at the place that they were living. I feel like they've been helping me with everything. And if you're coming in from long-time homelessness, you literally need help with everything. So I would say, what do I say here? So I think this quote really just, again, underscores how these housing programs, whether it's a daytime shelter or an interim housing program where you're there for 90 days, it really does, these places are shaping networks. And to pay attention of how the places where people spend their time may create maybe loose ties with people, but ties nonetheless, which confer behavioral, social influence. And this was from my doctoral student, Abby, who worked on the project with me. So all of this work combined led me to develop this framework that talks about the mechanisms of how place operates to shape health outcomes. And so I'll point out that there are 3 mechanisms of action: cognitive, behavioral, and social. And there are also 2 dimensions of how these mechanisms can work. So places can confer a protective factors like, again, the sense of control, a self of safety, adaptive coping, self-care. We oftentimes think about places as they're conferring risk, such as, where people experience internalized and anticipated stigma, or behaviorally where they're not adhering to their medication. So I just encourage us all of us to be looking at both sides of the coin as we move forward. And the other major point of this is the different scales that place can happen at. And one of the interviews that we conducted, there was a girl that talked about her safe space was a closet in her bedroom that she shared with her sister, and the first floor is where her parents lived, and the father abused the mother. So it was a very micro space, but it's where she felt like she could be safe. Okay, so we conducted another study with APAT and transgender women, and learned that the interpersonal violence they were experiencing wasn't just from like the police or people in the public, but it was from the sectors where they were seeking services. And so discrimination and stigma across sectors contribute to poor health outcomes through a variety of mechanisms, such as housing discrimination, profiling in police, lack of affirming care services, transportation options, and workplace hiring and discrimination. And so we realized that in order to actually address the violence and interpersonal violence that harms that these women were experiencing, we needed to develop solutions that approached all sectors. A multi-sector approach is one that aims to address all social determinants and recognizes that solutions cannot come from one sector or policy arena alone. So we used the community readiness model to inform this work. And this model posits that for communities or organizations, there are different stages of readiness to approach a problem. It goes from no awareness or denial or resistance that this problem exists, like we don't know any trans people, to being able to prepare and initiate programs, to ultimately be able to own the programs and sustain it. So we developed an in-depth interview guide to interview folks from the sectors, and which focused on leadership support, their current programs, and their policies towards transgender women. And we ended up completing 44 interventions, and you can see the different sectors that we were able to reach, which was pretty impressive. My community partners got a lot of good connections, but I really loved that we had a lot of legal government. We actually had one of the mayor's, major helpers in there, which was really cool. The private sector person was, I don't even know how we found him, but he was a owner of a pet store, and he said that he had a lot of transgender customers, and he would see them get, abused, verbally abused, and he's like, I just want to know what I can do to change this. So that was kind of cool. And you can see we have a good representation of age, race, and gender identity. Oops, sorry. So what we learned was that the readiness to conduct to provide gender affirming services was vast. Some people were barely doing anything, yeah, you're not supposed to be mean to trans people. Other people had safe space signage up. They were required to use pronouns of preference. Their forms tolerated it. And we also heard about some innovative programs. One program talked about how they would hire transgender women to help them during campaign season to get other transgender women registered to vote. One organization described creating materials to help their staff who had kids coming out as transgender or non-binary. So definitely some innovation. And this, we also in this project interviewed transgender women, and oh, sorry, that's what I wanted to say. Sorry, I'm getting tired. So we did the results, and then we had a convening where we had everybody that we interviewed come, and we presented the findings. So everybody came, and they were very quiet, and they said, I can't stay the whole time, and they sat there pretty stone-faced as we were presenting. And then we broke them up into small groups to do a capacity assessment and have a discussion. And the next thing you know, the room erupted in conversation. And I was like, I didn't realize they didn't know each other, and they were feeling very nervous and awkward about being put on the spot. So the next thing you know, they're talking to each other. They stayed past lunch. They're exchanging cards and promising to keep in touch. And I was like, did we just form a network? So that was really cool. I would love to do a follow-up study to see who's still in touch. And this is just a picture of the women's breakout group that we did. We interviewed them, and we wanted to make sure that the results got back to them. And they all, in addition to some of the suggestions of safe space signage and neutral bathrooms, they also said they would really love internship opportunities. So we passed that on to the sectors. Which leads me to, and I'm almost done. So what we realized after this, and all of that work was funded by the Bloomberg American Health Initiative. So what we realized was okay, people have various readiness, various capacity. So what can we do to help them build capacity and actually come up with changes to culture and policies? What we learned was that nobody knew how to do it. They're not behavioral scientists. Their jobs are to get people into housing, or their job is to make sure that they're keeping people on the street safe. So we got a high impact award from the Bloomberg American Health Initiative to do this project, which essentially is going to be working with the Los Angeles Police Department, the Sheriff's Department, and the biggest housing organization in South California called Hopkins. And we have identified 2 people from each of those sectors to be our implementation teams. We're interviewing people, boots on the ground, other folks, to understand what's actually happening. And then the plan is to give them monthly activities to do so that they can start changing the culture and the practices and the behaviors. And one of the things that we've learned so far is that people don't, it's not that they have any problem with transgender people, they just don't understand. And giving them a vocabulary list isn't gonna help. The list doesn't help me understand how to interact, because that's behavioral. So one of the things we're gonna do is see if we can get safe space signage up in the lobbies and the holding cells of the police department and the sheriffs. The sheriffs run the carceral system, and get them into all the housing units. None of the people we've interviewed so far have even heard of this concept. And I'm like, that's so, like, it's so different being in public health. The other thing we're gonna do is make some videos so people can see the humanity behind people who've transitioned either way. So I will let you know, hopefully in the fall, we'll have some progress done on this. And so in conclusion, where do I go from here, especially with all of the changes and challenges happening? My plan is of course, is to continue to work with the populations I've worked with. I enjoy them tremendously. They teach me what it's like to be real. I also plan to shift some of my research to be more community engaged, community partnerships, to focus on strengths and resilience as opposed to like just focusing on risk. So in the final seconds I just want to start with acknowledgements and acknowledge that somebody's, I'm sure, been left off the list, and I apologize in advance. But I want to start with my son, Riley. You've been by my side this whole time, like literally. And you have been so patient with me through the grant cycles, through the conference calls, through the travel, and I just want to appreciate you. It's also what I also appreciate is that at the end of the day, you remind me what's the most important, which is just being your mom. So whether I don't get a paper published, at least I'm still your mom. To my mom who is here, my dad is online, my brother is online, I don't know if my sister is. You know, hopefully now you understand what I do. But thank you for trying to understand all of these years. I would like to thank my formal mentors, Carl Latkin, Joanna Cohen, Lois Takahashi, and Alice Tang. My informal mentor, Kate, who is a fantastic listener and even better problem solver. My two work wives are not here because they're on vacation, but Melissa Davy Rothwell and Jill Ocharzik. I could call at any time of the day, and they would talk me off the ledge and help me stop overthinking. Of course, my Lighthouse family, who I know is online. You guys have really taught me what it's like to be a leader and how to have an impact on people's lives. Bert Queen, you know, what can we say about Bert? My APAT family online. You guys have really taught me how important it is to continue learning and not to think that you know everything and it's done. And through that, you've really helped me, I think, improve my science and improve the impact that we're having. To the students, all of them, the ones I've advised, the ones that I've capstoned, the ones that I've done the other things with, definitely the volunteers, like the ones I've had. You guys, your energy, your innovation and creativity are an inspiration. It helps me keep going when this is very hard to keep going. And lastly, the study participants. I don't think they'll ever really know the impact that they've had on me personally or on even the field, but I hope that my work turns back around and does something for them, because that's what we're all here for at the end of the day, is to have impact on the communities and societies that we serve. So thank you very much. I'm happy to take some questions.
Well, that was fantastic, Karin. Just very inspiring and just a joy to hear and to see how your career has really developed over the years.
Yeah.
It was a great story. So we have time for questions. We have people in the room, but also if you're online and if you'd like to ask a question, we'd love for you to just raise your virtual hand so we can call on you. Or if you want to type a question in the chat, is that okay, Lataska? We can do that too, but we'd prefer you to raise your hand if you do have a question. So let me just open it up. Comments, questions? Yes.
So, well, wonderful presentation. Thank you so much for having it. So while I was listening, I was wondering the whole time, like, how cross-applicable this framework is to other areas of public health like mental health, because this peer-led system really does seem to allow people to feel like they're less alone. So I was wondering if any research had also been done about that. Another question is that I know you mentioned the shooting galleries and how that has been like a staple in harm reduction, but has also like had those negative consequences. Have those negative consequences weighed more than the positive ones, or what is the overall stance that public health officials typically take on areas such as this? And also, I remember you like mentioned Ukraine. So on an international scale, has something like this ever been applied for HIV-related research or other research?
Okay, I'll try to remember those. I'll
Sorry.
answer the last one. So on applicability of peer-based approaches internationally, absolutely. This has been done in Moscow, lots of different places. So to be brief, there are actually 3 types of peer-based approaches. There's a popular opinion leader model, which is based on the premise that there are popular people in the community, train them, they will influence others. That doesn't work when people who use drugs, in my opinion, because who's popular? The person that has the drugs that day. So the model that we use is what's called natural helper, which means anyone that wants to get trained can get trained because we know that we're going out there to diffuse. And then there's the peer navigator model, which it is based on the premise that if you share a characteristic like breast cancer survivor, somehow then you're going to be a good peer. And I think that is the weakest evidence for that one. Yes, I think these methods are all applicable in rural. I mean, it hasn't been done everywhere. I know that one of my colleagues is trying a peer approach in a rural area with people who use drugs. But I think that that's why developing these frameworks are really important, because then you can try to apply them to different populations in different settings and see where they work. And your first question was?
My first. So it was about the application of it all.
Oh, yeah. Oh, shooting gallery, sorry. So I don't think, what's changed with shooting galleries is that syringe service programs are prolific in Maryland right now. And so we gave out in 1 year alone 17,000 syringes. So the goal is to saturate the community with clean syringes so that nobody has to use a dirty syringe in a shooting gallery. So I don't know that anyone's going to say, yeah, go use it at a shooting gallery, because they are definitely like not hygienic places. But if we can get enough clean syringes out there, it should be fine.
Because it's like sometimes a matter of harm reduction and not necessarily just shame-based.
Exactly.
Yeah, no, that makes sense. Thank you.
Other questions? Yes, in the back.
Good evening, Dr. Karin. That's wonderful work that you're doing. So I have also worked in HIV sector and with injecting drug users in my country, India, back home. So there was this unique problem that we used to face, that when we used to distribute clean syringes to the teenagers, their parents would come up saying that you are trying to increase the injecting behavior amongst them. It's just wondering if you've come across such scenarios here. Or
So back in the day, when during the during the tenure of Dr. Peter Bielenson, it was during that period that we did a lot of generation of the evidence to show that having syringe services not only does not increase injection, it also increases people going to treatment. So I guess I would suggest that you figure out who can generate the evidence there. It absolutely does not increase injection behaviors. It's kind of like using the analogy, like just because we use seat belts, that doesn't mean we're necessarily going to speed. Just because we have smoke detectors doesn't mean we're going to try lighting our house on fire. So I think if you use like more simple analogies, it can help people understand better why that's not the case. But it is, I mean, I get where it comes from, but the U.S. has definitely produced a ton of evidence that syringe service programs do not increase injection.
Thank you so much for your presentation. I was finding myself curious about the process of building trust with the community as an institution. From the Lighthouse perspective, I mean, you've shared about your own journey, and you've already been involved with the community and community work for quite a while, and probably built your own networks and built rapport with a lot of these people. But I'm curious at institutional level, what lessons you'd say you've learned over time about what other institutions can learn when it comes to building trust, especially with the sorts of communities you're working who have very good reason not to trust.
Sure.
Especially when you're collecting such personal information, where they're hanging out, with whom, and what dates. It takes a lot of rapport and trust to build.
Yeah, absolutely. Well, that's one of the reasons why our clinic is over there and not here, because we know about the historical distrust of Hopkins. I've been doing this for over 20 years, and I think my number one rule is hire good people like Tanya, who had the credibility, who can teach me how to be credible with them as well. It's also just spending a lot of time actually talking to the participants. Like, I've done everything from work the front desk and answering phones to making calls for retention, and that's how they start to believe, like, oh, maybe they're not just going to dive in and dive out. We've been around for a while, and we also make sure that our security, when people come in the building, that security are trained. No stigmatizing anything. I don't want to hear about it. In fact, our security officers are amazing and really do care about the community. And so I would just really focus on who are your people and making sure that even if you're in a position of leadership, you're listening to what they're having to say, because they're hearing firsthand what's happening.
Hello. I really enjoyed your talk, which
Thank
I
you.
think is quite applicable to so many of our fields outside of your area. Your slide on the cascade, I guess have several questions about it. I'll just do two of them. So the first is, what's the denominator here? Is it all adults or is it
My
just
sample.
your sample?
Yeah.
Okay, because I was thinking, I had June Park in a class that I gave, and
Okay.
she basically said, they really need to be targeted to the people who are likely to
Yeah.
see or have. So that I think is important. The second is, here we are in East Baltimore, and I've asked myself, should I actually, get Narcan and
Yes.
have it available?
Yes.
So
I
then
was going to
guess-
bring
so
some, but
I'm
then I
calculating.
thought, I don't.
You should fail me for that, asking that question.
No,
But
no.
maybe there should be a better way to advertise that and make everybody aware that.
Sure, yeah. I mean,
'cause
if
I don't
any,
think it happens.
I will just say, if anyone wants naloxone, send me an email. I'll happily deliver it to your office and tell you how to use it. I almost had to use naloxone just a week or so ago on somebody that OD'd right by our cart. It's literally squirting it up their nose. Oh, maybe last question? I will just add, though, for the folks in the room, that there are 2 tranquilizers that are being mixed in the drugs that are not opioids, and so naloxone won't work. So we still really need to call 911. But if they have any opioids on board, that'll help them maybe reverse some of the, what's it called? What medical student people, resuscitation. Yeah, respiratory depression, thank you. Okay.
Yeah, how do we convince these injection drug users to come to the clinic so that we could help them with such things?
How many times?
How do we help them come and use the services? How do we convince them to come to the clinic?
Oh, they see us and they come running.
Okay.
Yeah. If word on the street is a very, this diffusion of information and materials is a powerful, it's the diffusion of innovations theory. It's really like one person will come by and then within a half an hour, we've got 20 people lining up. So, and they know we have snacks, they know we have feminine hygiene products, they come. So, and then also I think that, again, just being authentic and, we're just really approachable people. I think the scariest thing that we have on us is our badge.
Can I ask one quick question?
Thank you, Kate, for coming.
Can I ask a quick question?
Yeah.
I mean, Karen, what would you do if you won the lottery?
I would still open up a harm reduction center. Or I'd fund everybody's research.
Well, Hopkins won the lottery with you guys.
Oh, sure.
Go ahead.
Hi, thank you for sharing your work. I was just wondering if you could speak a little bit about how social media has changed your research over the even past 5 years. I feel like the landscape has changed a lot.
Yeah, that's a great question. It hasn't changed my research. I think that the social networks on social media are operated very differently than our own social networks. And I think that I'm pretty skeptical about, I'm not skeptical about social media, but I'm skeptical that their influence on behaviors is as strong as people purport. If that were the case, why isn't everyone vaccinated? You've got these NFL stars endorsing it. You've got celebrities endorsing vaccination. People are still not getting vaccinated. So if social media were that influential on behaviors, I think we'd be in a different situation. It would be great if it was, but I just stay clear of it. I'm kind of old school that way.
Yes, up in the last row.
Hi, this is Mumini.
Oh, hi, Mimi.
Yeah.
I didn't recognize
So,
you.
thank you for your presentation. In community engagement, when I attend many presentation, people used to say, in community engagement, make your friends before you need them. So, how do you think you apply this to your work?
The saying is make your friends before you lead them.
Yeah, so need them.
Need them.
For
Oh.
example, during COVID-19, in my country, when medical doctors tried to talk to the people, some refused to listen to them. But in my area, it was very easy because 10 years ago, we started a community program. So it was easy when COVID-19 came because we were already
Right,
friends.
right. Okay, I see what you're saying. Yeah, I mean, I think that part of that is just being willing to, get out of your office and just hang out at the waiting room and talk to the people coming in and just being consistent about that. I wasn't credible in the beginning. I had to rely on my staff who knew the areas and knew the people, and they were the faces of the project. But then as I learned over the years, the other thing too is I've given a lot of time to just free work to other organizations and agencies because we have the capacity. I tell them the greatest resource that Hopkins can give you is our students who have to do capstones and thesis, and they're free labor, and I'm happy to guide them. And I think that's a way to really show the community that we do care about them. Most of these organizations are so small budget, they don't have the capacity to even think about questions that they want to answer. But when I learn of a new organization, I usually reach out and I say, I'm not asking for anything. I just want you to know that I am here. If you need help with anything, I'm happy to help you. Just as a starter, get started with a list of questions you want answered, and then we'll work together and come up with a way to answer them. And I've done a lot of really fun projects here that were funded by the Learner Center or Bloomberg American Health Initiative to answer these NGOs' questions that they didn't even realize that they had. So I think there's another question back there.
Yeah. Good afternoon, and thank you so much for the great presentation. It was really impressing. So myself, I had worked with the Drug Reduction and Elimination Action Plan for country India for a brief period of 1 or 2 years. So we had some challenges, like as an external aided project, if we are going to the community to engage some like drug reduction or focusing the adolescent, it seemed like even if though it seemed like we are taking the confidence of community, at the implementation we were not able to achieve what it was supposed to be achieving. So when we approach the community through the departments, like departmental approach, like like education departments and the women and child departments all combined together, we are approaching the community. Things seems to be working well, but still we had challenges in terms of policy and law. So in your work, like how did you feel like bringing the policy and law into like working along with the campaigns or interventions you were doing, or like evidence-based research on implementation role? Like how is the role of policy and law in your works?
So, I mean, yeah, seeing policy change, it takes forever. One of the things, though, that I learned, particularly in my work with transgender community and the police and the sheriffs and the policies exist. Like, That's not the problem. The problem is people don't know how to implement the policies because they're not behavioral scientists. And so I thought with this last project that I'm working on that we are going to have to like literally try to get the chief of police to create a policy on gender affirming services. It exists. It exists actually at the federal level too. So it's really figuring out do you have the policies really, and maybe you don't, but if you do or have a semblance of one, why are people having a hard time implementing the policies that exist? So thank you.
One quick question? Yeah.
Sorry.
It's okay.
I liked your question on social media, and I was also wondering if there's any way to spin that negative influence that social media has into something that could be more positive. Because you talked a lot about how in Baltimore you have these centers and people are able to go there, but it's a more urban, more populated area, and they're lucky enough, like, for better or for worse, to have Johns Hopkins and these educated individuals like doing this research. How could you spread that incentive to more disenfranchised communities which may not have like the Hopkins bubble to get information from? And also, how do you continue having that more grassroots initiative that is based on community and connection between the individuals through social media in a way that's not flashy?
Yeah, I mean, we've tried to do this. It really hasn't been that successful, but asking people that are in our projects to go on social media and spread the word. And the problem with social media, as we probably already know, is you have to do it every day, and it's the algorithm. So, asking people to post once is fine, but asking them to post more than once is just like a burden to them. So I guess I don't have a good answer on how we can use social media, but I'm also not a social media expert. I would ask them.
It's very glamorized. They only want to see the beauty in it.
Yeah.
Not the real.
Great. Well, with that, again, thank you so very much for the lecture today, but more importantly, all the work that you've done and will continue to do. We look forward to seeing the results of your ongoing studies in the near future.
Thank you.
So congratulations.